We're going to start our presentations now. First, I want to just thank everybody for coming out here. I know it's a busy day for many people, and we really appreciate that everybody came. I know this was very last-minute notice. I want to explain how this event came into being. We actually were sitting around in the office just last week and felt that we have been talking about something like this for a while, doing an event where we can really... There are two goals to this event. One is for transplant recipients to meet other transplant recipients, because sometimes there's a lot that can be gained by speaking to somebody who's in the trenches, so to speak, who's really dealing with it. And maybe what works for one person can work for somebody else, and different tricks to the trade. And also certainly to hear from the doctors that we have here today, a wonderful, we'll get to the wonderful speakers that we have. And certainly to learn as much as we can about maintaining health after receiving a kidney. And we had been talking about this for a while, and when we sat down last week, the idea came up that we got to do this. And we got to do it right away because we were excited. When we get excited in the office, we got to just move forward. And I know to the outside world that might look a little bit crazy to put together an event in the span of less than 7 days. But when we have an idea and we are excited and passionate about an idea, we're ready to roll. So I thank everybody for certainly for coming, and certainly on short notice. It really is appreciated by Renewal, and hopefully you'll learn a lot today, and it'll be a very enjoyable experience for everybody. Before I introduce the doctor, I want to just start off with a thought. The Torah portion that was read last week discusses something very remarkable. It discusses the story of Pesach, or Passover, and it's the beginning of the process of the story. And in the story, what we're told is that the Egyptians, when they were enslaving the Jewish people, they had instituted, unfortunately the Nazis learned this lesson very well as well, they instituted taskmasters. They instituted Jews that were responsible for essentially overseeing their brethren, overseeing their own. And if the quota was not met for the day, so not only were the individual slaves beaten, but those who were assigned to the job, the taskmasters, the overseers, they were the Jewish police, if you will, and they were beaten mercilessly on behalf of their fellow brethren. And we are told that they took on the brunt of the beatings so that their fellow Jews did not have to suffer. And so they would take on situations where the quota was not filled, they would take it on themselves so that to avoid the pain and to avoid the suffering for somebody else. And I think it's a remarkable thing that when somebody does that, when somebody takes on pain and suffering for somebody else, and what it really shows is that why did they do that? They did it because they understood on a humanistic level, on a spiritual level, they understood that everybody is worthwhile. Everybody is worth saving, and everybody is worth treating like a person, like a human being. And that our renewal that really guides our philosophy and our principles, that every life is worth saving. And we want to save as many as we can, and we try and save as many as we can. And all of you here today are proof of that principle, proof of that guiding vision that Renewal has. I want to also make mention of the Renewal staff that is here today. I want to specifically mention, I'll mention everybody. We've got Menachem Friedman over here, our program director. We have AJ Gimdi, our community advocate. David Shisha over there in the back, our jack of all trades, does everything behind the scenes. We've got on the ladies' side, we have Rivki Gutman. Everybody here is very, very familiar with what Mrs. Gutman does and all the care and concern. It's one thing to call somebody, it's another thing to call Rivki, and to call her and to feel the warmth and to feel the embrace that she brings to the table for every single patient that comes through our doors. So we are very privileged and pleasure to have her not just here with us today, but as a part of our Team Renewal. We also have Irit Lang, who's somewhere in the back outside, who really is behind the scenes takes care of anything and everything, and many of you have already met with her and have gone to see that. And certainly the rest of the Renewal staff that is not here today, couldn't be with us today. Mendy Reiner, our founder, asked me to express how sorry he is that he couldn't make it today. He actually was planning on coming. He woke up this morning with a very bad cold, and he figured in a room of immunosuppressed patients it was not the best thing for him to come. So despite as much as he wanted to come, he had the foresight not to, but we certainly miss him. We have today with us, we're very privileged at Renewal to have a number of medical professionals that we work with. And each one of them brings a tremendous amount of talent and experience to the table, but there's something else that they bring, and that is not just a loyalty, but that is a particular passion for what they do. There are a lot of medical people out there, there are a lot of doctors out there for whom their medical profession is a job. It's something they do, and then they go home and that's it. And then there are the doctors and the medical professionals that go above and beyond. Those are the ones Renewal likes to associate with. We have Dr. Kleiner here with us, who is an exemplary, really the epitome of that kind of a doctor. He does not have specific hours. His office may be open specific hours, but his phone is always on, and he, not just as a doctor, but as a sympathetic ear, he's there to listen and to give guidance to patients. He is a nephrologist, a very renowned nephrologist, based here in the New York area, and he has guided many of our patients pre and post transplant. And it's a pleasure for us to have him as a part of our team. He's already standing up, so I have to stop the introduction. But we are very fortunate to have with us Dr. Kleiner.
If you don't get up when a rabbi's speaking, you're never going to get up, so forget it this time. Whatever introduction for me, my introduction is to you, that I am profoundly moved and honored to be here today and talking to you. I've watched over the years, looking around the room, a lot of you weren't born when I did my first transplant and managed my first patient 43 years ago. And I'd like to give you good news, those of you who are 5 years, 10 years out. I now have 2 patients who are 40 years post-transplant, no rejection, and about somewhere around 10, 12, 14 patients, 30 years plus, and then the 20s and etc. So the world has changed. But the pain that I went through all in the early years in terms of matching, the statistics, as you know, were horrible. 70,000, 80,000, 100,000 people waiting on lists 5, 6, 7 years. And the processes that were put into place were so disappointing. There were issues of ethics, there were issues of halacha, there were issues of waiting too long, because you all know that the ideal is, and I'm totally dedicated to it. I own a network of dialysis centers, but my job is to avoid dialysis, and that's my goal. I pray that before my career ends that I'll be put out of business. Not by the government, but by God. The longer one waits, the more complicated it is. To me, a preemptive transplant is one of the most exciting things, and I'm totally dedicated to it, and because of Renewal, I've become more successful as part of that team in doing that. And the results are very significant. Renewal was too long in coming, but I needed you, and the community at large needs you, and we need to have support. And also, when I look at each one of you, I think of the heroism that you represent, the things you went through, your families went through. I went through it with hundreds, and actually more than 1,000. I've trained most of the nephrologists that you work for, And I watched and I went through these things, but I also am in awe of each one of you, at least most of you, the people who are not in this room, the people who have donated kidneys to friends, relatives, and strangers. Their heroism is beyond my imagination. I actually manage many of them, because once a person has a single kidney, there are aspects of their health care that have to be followed. And I do follow many, many kidney donors. I think by ethics I should stand up for them when they come into the office, but I don't want to spoil it that much, so I'm going to keep it there. Rifki, who tells me that we met about 30 years ago, I didn't know about that, but I'm honored to be here. Of course, I had no idea that I was actually speaking in front of a podium. She gave me a nice outline. So I'll work with that a little bit, but I want to talk about a few things. The issues in following a recipient are not just straightforward issues. They're wonderful issues. It's a lot better than managing a patient who's a CKD patient. But in terms of managing you all, it is very important that you have a good relationship with the nephrologist and the nephrologist team that includes often the physicians who manage the other issues that many of you have, that many dialysis patients and kidney transplant patients have. Many patients have diabetes. That's the #1 cause of kidney failure in the United States and the world now. It used to be other things. Patients with heart disease and other illnesses. There are very few patients who don't have other comorbidities. So the nephrologist who's managing a recipient should be very well versed in medicine overall, should work with the team, has to work with nutrition, has to work with infectious disease at times and other subspecialists, and I'll mention some of them in a while. It's my rule, and I have kept that rule for 40 years, no matter how well you're doing, I want every recipient to be seen by me once every 3 months. I get blood work in a timely fashion, I can react to problems, I can discuss things, and we can pick up reversible problems. If there's a problem that occurs that can't be reversed, that's a waste of tremendous of good kidney and good person, and etc. So I do not accept for ongoing management a patient who's not willing to come once every 3 months. Those of you who know me, that's not because I need to keep my practice busy. It's the opposite. My practice is overwhelmed. I want to say one little disclaimer, but I'm willing to talk independently later. I cannot, and I should not give individual advice on any specific patient. And I'm not recruiting any of you. But I'm willing to give some steerance on that. The medications. The good news on medications is very good news. One is if it's a living donor, you use less immunosuppressives. And over the years, the immunosuppressives that we use are less stringent, are less toxic than we used to in the old days, but they still deserve a great deal of respect. The one drug that we particularly have had great success with in terms of decreasing and diminishing and sometimes removing altogether is prednisone. Prednisone is a very, very helpful, very powerful, and very toxic medication. So those of you who are on prednisone, hopefully the dose is the minimal that you need, and you have to follow for the side effects. Some of the issues that we look for in all the immunosuppressive drugs, and I'll talk about all of them, the cyclosporin, FK, and the newer ones, Cellcept, etc. They all have in common certain side effects and certain areas that have to be monitored closely. You are all experts on this, and if you're not experts on this, your nephrologist has to be counseled. Prednisone itself and the others cause immunosuppression. So I congratulate the founder for not coming here and sneezing on all of you, because you are immunosuppressed. You're not ridiculously immunosuppressed. It's not like, God forbid, chemotherapy patients for malignancies. but you are somewhat immunosuppressed, which therefore means that when you have a cold or you have a fever, those of you who are teachers, etc., you have to be particularly careful about things like that. Some of the medications in terms of the immunosuppression are not an issue just of immunosuppression in terms of infection, but the immune surveillance of the body towards malignancies is affected after many years by being on immunosuppressive drugs. I still, to this day, have my patients seen by dermatologists once every 6 months or so, because skin cancers can be not only more common, but they can be more aggressive in people who are immunosuppressed. So I'm very much an advocate of following those things. There are other malignancies that are particularly prone in people who are transplant patients and immunosuppressed patients. And it's one of the things when a patient does not ever reject their kidney that can cause problems that's an issue. The immunosuppressive drugs themselves, if I'm talking too quickly, just I'll slow down. I'm going over what I learned in 40 years. I want to do that and try to do that in a few minutes, but I'm trying to give you highlights. The other issue is, of course, the effect on diabetes, particularly the prednisone, but other drugs, so that diabetes has to be carefully monitored. There has been some significant changes in the approach to diabetics, and that is that when we used to do non-living related transplants, we don't call them what we used to, we call them deceased. We used to call them something else. We used to call them cadaver. Didn't sound nice. So in deceased, the issue that we had there was that there was a significant issue of what the kidney had before, etc. But most important, concerning the immunosuppressors, we do have to be concerned about the effects on the kidney itself. The famous one is cyclosporin. One of cyclosporin's toxicities is hypertension. We can manage that. A little bit of diabetes, but it also causes kidney failure. So we have to manage at the proper dose, manage the levels. That's again why I see my patients frequently. I do follow the levels of the cyclosporin, the FK506, the other medications, and it's important to use if people are doing well. And my measure of doing well is the absence of a high creatinine and the absence of proteinuria. Your nephrologist should be following your urines. Before I go into the room to see the patient gives us a urine. The absence of protein is a very good sign. The presence of protein requires further evaluation. But if patients are doing very well, especially after a few years, the goal is to use the lowest dose possible of those immunosuppressive drugs so that we do not get the other side effects. And that's an important part of it. I am a strong advocate of, and particularly what's going on in the world today, to my enormous chagrin, I'm a very strong advocate of vaccines. There was a period of time where for the first year after a transplant, one of the major transplant centers did not advocate giving flu vaccine. Now they all do, and all of you should have had one this year. It's working this year, so there's nonsense about last year. It didn't work. Fine, it didn't work last year, but it does work. Even if you get the flu, or get a little bit of the flu from the vaccine, it's not as severe and not as life-threatening as not of having the actual influenza. Tamiflu is safe in renal failure patients. The dose has to be adjusted. But don't get the flu. And I'm just very disturbed about what's going on with vaccines. I see brilliant people, smart people, who, for reasons like superstition, really, are not protecting themselves, their families, and their neighbors. So that is an important aspect. Nutrition. I'm not into fancy nutrition. I don't have strong opinions about anything other than good food is good food, good nutritious food, but you should be working with a nutritionist. It depends on what your other diseases are. But one of the benefits of having a transplant is you can eat a lot of food, including some foods that have some salt. You can have a concoction that is toxic On Shabbos, kol cholent, but you're allowed to have it. I come from German Jewish background, so we never had that toxin ever. But anyway, I know it tastes good. As far as exercise is concerned and lifestyle in general, the goal is that you got your transplant, so live a good lifestyle, enjoy yourself, travel, have fun. Exercise is just as important as, are you pointing to me?
I don't know if it's safe.
What?
I don't know if it's safe.
What's safe? I'm talking about exercise. Yeah. Okay, I'm going to talk about that right now. Exercise is critical for all of us. You know, you're not different. You don't come from Mars. You don't come from a different planet. You're humans. With your transplant, most of what you have to do in terms of lifestyle and meds and sleeping at night and fighting with your spouses is the same as everybody else. So exercise is critical. I don't like heavy weightlifting. I don't like bulking up. The best exercise that all of us should be doing is aerobic, walking, treadmill, things like that. A regular program. I have some patients because I come from an area where there's a lot of this in the culture, where some of my patients bulk up and they become so muscular that they end up making that single kidney work too hard. You have to remember let's give a little physiology, a little bit. We're born with 2 kidneys, about 2 million nephrons. Each one of those 2 million nephrons does 1/2,000,000th of the work of a kidney. Now, if you don't have 2 million, you have not even 1 million, let's say you have 1 million, so each one of those is doing double the work. So don't expose that kidney to too much work, i.e. do not give it too much protein. Red meat is not a good thing for a transplant patient, and being too heavy and too bulked up is not a good thing for a transplant patient. So what you really want is to eat good nutrition, have good exercise. Did I answer your question, young lady? Did I cover it? Okay. I'm going to stop fairly soon because I do want to have this as interactive, and I'm covering a lot of different areas. There are some other issues.
Sorry. Just in terms of the interactive, you all have index cards on the table. If you want to write down specific questions, I'll come around and collect them, and we'll bring them to the front.
I'll also answer directly, and you don't
That
have to.
works too.
Well, the more, in quotes, prominent I've gotten in my career and my life, the more I've learned, the more informal you are, the more fun it is. But he's my rabbi out in Staten Island, so I got to show a little respect. He's my rabbi. I know him as a little kid also, but times change. Anyway, there's some questions that are brought up, but I want to just summarize some of the things I said. Get seen frequently, have a competent nephrologist who has a team, do your exercise, eat good nutrition. I'm not going to tell you to eat some kind of, something special. There's no literature on any of that, and I can't advocate. I'm not against anything like that. Drug interactions, though, are very, very important. Do not have your dentist write a prescription, or your GP write a prescription, or your next-door neighbor give you a prescription without clearing it, because that's, these kidneys do last around unless you mess it up. And you can mess it up with the wrong dose of the wrong nothing, like an aspirin, a non-steroidal nothingness, a Cipro at the wrong time. Has to be dealt with. If urine infections are important, they have to be treated properly, and they have to be suppressed properly. There are issues that come up. I'll put some little side issues and talk about 1 or 2 other things, but I do not want to bore you all. Removal of a fistula. Those of you who are on dialysis, do you remove your fistula or not? That's a case-by-case basis. If it's not causing any problems, we don't remove it. Removal of kidneys is another issue. Very large infected polycystic kidneys, and there is a lot of that in our population. That's one issue. For the most part, we don't remove rejected kidneys, failed kidneys. That's a problem. I had a patient a short while ago who ended up with a renal carcinoma and a rejected kidney. So there's always a balance there. I take care also, this is some side issues, of patients who have other transplants. And because of the medication, they often end up with kidney failure as well. So I have patients with heart transplants, liver transplants, not too many lung transplants. It's not been too successful. And we have to watch them closely. So I manage a lot of those patients who have dual transplants, heart, kidney, at some point, and it gets a little complicated. I wanted to go back to the issue of the diabetes for a second. When we were doing just deceased transplants, we were also doing pancreas transplants. It is not out of the question, however, now in some of the centers, some of the really good centers, that even if it's a donor transplant, you can't get a pancreas, but there can be pancreatic transplant related to that as well. And that's something that we are exploring a little more frequently. Having a new pancreas cures diabetes, obviously. So we can look into that. Let me go over Mrs. Gutman's list, because otherwise she'll be unhappy with me. I got most of it. Washing your hands. The typhoid epidemic and the Black Plague that occurred in Europe during the Dark Ages was the first evidence that if you washed your hands before eating bread, which the Jewish people in that time did, nobody else did, you would avoid plagues. 200 years ago, the most common cause of death of pregnant women during labor and delivery was the obstetrician didn't wash his hands. There's no, and if I walk around my hospitals, I would say half the time, half the doctors do not wash their hands between patients. It's a plague. Give me a plague. That was my pun. You didn't get it, too bad. Okay. Here, let me come home. Salt. Depends. If you don't have diabetes, you don't have hypertension, you got a nice kidney, enjoy your salt. Again, it has to be individualized. You don't have to do things that are inappropriate. She put smoking on the list. Rick, are you there? Do you mean marijuana or nicotine? Okay, so we're not clear. Alcohol is not contraindicated in appropriate amounts, and certainly there are some benefits to small amounts of alcohol in the diet, depending again on medication. Any medication or any over-the-counter or any natural drugs or homeopathics, many of them are not well controlled, especially the ones that come from China. Trump didn't tell me to say this, but you're supposed to say China, right? Are very dangerous. They're not properly managed. I don't think any of you should be taking those things, unless you have a very specific producer of these things. High doses of vitamins can be very toxic. The best example is vitamin C. More than 1,000 milligrams of vitamin C a day causes kidney stones. You don't need a kidney stone in a single kidney. That's again a significant thing. I covered most of her topics, and so I think she'll invite me back in another year. But the summary is be smart, go smoking.
Yeah. Can you address that? Is it an issue?
Is smoking an issue?
Yeah. Good.
Smoking is not an issue. It has nothing to do with transplant. Smoking has to do with not committing suicide. Smoking is suicidal. There is no discussion. That's why,
My question is, it worse for a transplant recipient?
It's just as bad, except that he's immunosuppressed, so his chance of getting a malignancy quicker is higher. Chance of getting cardiovascular disease is higher. Chances of getting peripheral vascular disease or losing a leg or a foot is higher with smoking. Chance of getting a stroke is higher. We hold these truths to be self-evident. If any of you who've gotten a second lease on life, if any of you who have children and wives who don't want to suffer, not only die, maybe dying is, it's easy to die, but who don't want to suffer, it's inconceivable to me that you smoke. Now, marijuana, the jury's out on marijuana. That was my joke. So please, I'm glad you asked me to elaborate. I'm going to come into one of the things that's one of my favorite topics, and that is pregnancy. I am a massive advocate for pregnancy. One of the wonders of transplant that occur very quickly after a transplant is the resumption of the patient's ability to be fertile. Both the male and the female, the sperm counts come up, they become normalized. the female also. The official ruling on that is to wait about a year to make sure there's no rejection. Most of my patients get pregnant before they leave the hospital after the transplant. Some of these jokes are not jokes. Don't get pregnant. Doc, what am I supposed to do? I'm pregnant already. Thank you very much. There are very few contraindications. Now remember, it's a single kidney. It works harder. And the patient has to have really good kidney function, really good blood pressure. All of the medications have to be adjusted. They can't be on a lot of medications, but there are safe medications, and there is a way of managing. And one of my biggest prides that I have is that I have a major number of patients who have had children after transplant. I have one young man, my super pride, and I have a picture of him in my office, who has had 7 children. I have some of my female patients who have had 2, 3, and 4 children. If your nephrologist or your obstetrician is afraid to manage you, or someone you know well during a pregnancy, find another nephrologist. This occurs with other people, with the CKD patients before transplant, etc. People want to be pregnant, and one of the problems dealing with the Orthodox population, and if you notice, because you're a mixed crowd, I did not use any Hebrew words or any other things like that. I try to keep it pretty American, which I am anyway. I don't come from Brooklyn. I come from an outer borough. I'm not sure there's any Judaism on Staten Island, so we'll see. The issue there is where sometimes the doctor, the obstetrician says, "Oh, you had 2 kids already, it's okay." That's obviously, there are different cultures and different philosophies, and I have a strong feeling. I don't want to spend too much time talking. I've covered a lot of topics, but I could take some questions. I can't answer anybody's specific case issues. That would be unfair to everybody, but I can answer a few questions, and if Rabbi Stern wants to hand out cards.
We don't need to do cards.
Okay, he says we don't have to do cards. He listens to his balabas. That is the first Hebrew word. Okay, anybody? Yes?
You mentioned about PKD.
Can you be a little louder?
You
Yeah.
mentioned about PKD, removing the PKD kidneys.
Sometimes.
Right, so the question, there seems to be a very big debate amongst the community, among the medical community, pro or against. And I'm trying to figure out, do you just follow your surgeon, or do you just, because you mentioned before that you had patients who left them in and then it became problematic.
I don't think it's a big debate. My problem is
What's the question?
I'll say the question: removal of polycystic kidneys. Okay, I'll do that from now on. I don't think it's a big issue. I think it's a case-by-case issue, and it's never left to a surgeon. Surgeons are supposed to do what a nephrologist tells them to do. That's my little bias. It depends on their size. It depends on whether they're infected. It depends on what they're filling the abdomen so much that the balance is off. But otherwise does not have to be removed. We like to leave kidneys in because they still produce hormones. They produce erythropoietin. They produce medications that affect bone disease. They produce vitamin D. So we try not to remove unless. So the answer to your question is, it's not a debate. It depends on if there has to be a specific indication to remove. Otherwise, you leave them in. Okay. I want to talk about bone disease because I just thought about it. Bone disease is a major problem. The parathyroid disease that occurs in kidney failure, it many times gets worse after a transplant. So that has to be managed as well. Measuring the parathyroid hormone, using the right medications, the Sensipars, the Hectarols and things like that, or even doing a parathyroidectomy, taking it out, is part of the successful management and following of a patient who's going to get a transplant and who has a transplant. That's a complex topic. It should be dealt with properly. Next question, if there are any.
Isn't that usually a endocrinologist?
The question is, should an endocrinologist manage parathyroid disease and renal failure? And the answer is no.
Not renal failure, but the thyroid.
Parathyroid disease and renal failure is more related to the overall disease process than what an endocrinologist deals with. In my opinion, I like endocrinologists very much, but I think the management should be by the nephrologist. Other questions?
You referred earlier to cadaver kidneys.
I said deceased.
Well, not surprisingly, for people who are diagnosed with end-stage renal disease, it's enough to make anyone depressed. But with
Yeah.
chronic kidney disease, so many patients are diagnosed, not necessarily treated, but diagnosed as being depressed, some of which may be a consequence of physiological changes rather than depression. And to what extent are whatever psychiatric liabilities that for both chronic kidney disease reversible post-transplant?
Your question is excellent. I'll repeat it. Psychological disease in the patients with kidney disease, patients who get transplant, etc. How much of that could be physiologic? How much is psychological? And it's a combination of both. Many patients post-transplant do improve significantly psychologically. As you know, part of the evaluation for transplant is a psychosocial evaluation. There is significant improvement. I take psychological status of the patient very seriously. I do regularly have my patients seen by psychologists, psychiatrists, pre and post-transplant. Occasionally you get a patient post-transplant who can't handle the wonderful success, and they have to be dealt with psychologically too. Your question is very important. The challenge is enormous, and I'm glad you brought up that question. It's a toughie. It's a toughie. And then you have to deal with the psychological trauma to the nephrologist, who has to deal with patients, and it's not a joke. I deal with patients their whole lives. I know their families, I know their children, I know their parents, and I've dealt with them 25, 30 years, and if something bad happens to them, it's not easy to deal with either. So I think a lot of nephrologists can use psychological help. You know. Not me, I just, yes.
Getting back to the bone issue. So I know you said the point of marijuana is non-effects, but what about CBD oil for helping the bones?
Yeah, the answer is I'm looking forward to good studies establishing that. I'm optimistic about that. But, well, let me say one thing. It doesn't, the question about using the oils, the cannabis oils, in terms of the effects on bones, it doesn't change parathyroid disease now.
No.
So, no, it doesn't. So there may be a role. I wasn't joking about cannabis in general. There's a role for cannabis, and I've been using it for many years in certain circumstances. But the mistake that a lot of us are making is not addressing parathyroid disease. You know, PTH hormone, you know, it's supposed to be 200, 300, 400, you know. Then you get a patient post-transplant, it goes up to 800, 1200. The only thing that's going to deal with that is specific meds approaching the parathyroid and specifically at times during the surgery. I don't know the answer to your question.
So when you talk about bone issues after transplant, you're just really addressing the parathyroid.
No, I'm also addressing the effects of steroids. So osteoporosis itself, steroids, diabetes, weight issues. No, I pointed out one that's specific and a troublesome one, but bone disease is a major issue. Most of the patients that I mentioned before, 20 years, 30 years plus, one of the biggest issues they do have to deal with is fractures, is knee transplants, hip transplants. Many of my patients have that challenge. It's a big challenge. It's a big challenge. Parathyroid, other effects. That's why I'm so happy when patients get off steroids.
Spoke about supplements. What about them taking prenatal or what during pregnancy?
Most of the prenatal vitamins are perfectly safe. They're certainly post-transplant, yeah. They're most are safe. The combinations are good. So I do let my patients stay on prenatal vitamins. I don't let them stay on things like enalapril and things like that. There's a whole list. It has to be managed, micromanaged properly. But prenatal vitamins are good. I think that's it. Am I done? Huh? Don't hear your question.
Probiotics,
I
multivitamin.
have no comments on that. I said beforehand I was not going to comment. I don't know. I don't know of any medical studies in renal failure that discuss it one way or the other.
My doctor probably very much against it.
And this is not the forum for it. I have my own personal opinions. I can tell you about my patients vis-a-vis probiotics, but I want to stay down the middle of the road. And the middle of the road is no controlled studies. Everything I've said today is based on scientific evidence, published scientific evidence, not my own opinion about anything. This is scientific, and I don't have scientific evidence to make a comment. Most multivitamins are safe. Not high-dose vitamin C, not high-dose vitamin A. Regular multivitamins are okay. It's the nonsense where they cook, super doses of certain things. They are dangerous. They're not just not necessary, they can be very dangerous. A single multivitamin is fine. Young lady in the back. I get a lot of questions.
What about time?
You said no one's going to listen to me. What?
By time release, vitamin C.
It's the total dose that matters, not the release. Once you get above 1,000 milligrams a day, it affects a hormone system in the body that changes pyruvate to oxalate. If you want to put the audience to sleep here, and it makes you make more oxalate. Oxalate is part of kidney stones. So it's not the rate of release; it is the thing. I didn't talk about one other thing, which I do want to talk about because as it comes up, I didn't have time for everything. Is anemia. The beauty about a transplant vis-a-vis anemia is once the iron deficiency is repleted, which can be done safely, anemia enormously improves. It's one of the enormous benefits of getting a transplant. Patient's anemia goes away very quickly, and that's because the new kidney, is producing that special hormone called erythropoietin, and the other causes of anemia are being eradicated. So anemia is one of the great benefits of the treatment of anemia of having a successful transplant. And that's very exciting. There is certain times where the anemia gets better too well. That's not for today.
I think we'll stop there.
I have one more.
One more question.
It's not nice to say no. Go ahead. I'm having a good time. Yes.
What could be the cause from low platelets, getting low platelets after a transplant?
There are different causes. I'm sorry. It's a long story.
What can you do?
There are different causes. Sometimes they require bone marrow transplant and replacement, etc. But that's not a standard problem and a specialized problem. I'll take one for the guy in the back because he's so pushy here. Go ahead.
Has any work been done, any studies at all, on the psychological effects after being a donor?
Yes, that's a very good study. Very good question. The question on the donor: what happens to the donor after this is all over? We tell the donor, go home, don't worry about it. Who cares about you? The opposite. No, the donor is a very important person. There's a rule that the impact on the donor, disease of the donor, complication of the donor, has to be close to zero, otherwise it's unethical to accept a kidney. So there's a whole bunch of discussions I'm not having now about who can be a donor, who can't, and how we turn people down. The psychological impact on a donor has to be dealt with, and many times they are elated and they feel empowered. What's very interesting sometimes is the worst psychological impact is if the donor is from one sibling to another. It changes their relationship. The anonymous donor, we don't have as much. But that's a whole different subject. It's published. There's a tremendous amount of literature on the psychological, positive and negative impacts on being a donor. It's not ignored. It's a very specific issue. Who can be a donor? Who can't be a donor? I can give you another hour on that one, but there's a lot of literature. I'm being told to stop, and I should stop.
Thank you so much, Dr. Kleiner. We will have more time for questions afterwards. We still have another wonderful speaker. We're going to break now for soup. Soup is going to be served. That's very important stuff, too. And then we will commence with our second speaker, who will be available to answer many, many more questions as well. I also just want to take this opportunity to thank Mrs. Solomon, to thank Mrs. Friedman, Mrs. Grossman, who really were very involved in organizing everything for today's event, so very much thank you. And our next speaker, Dr. Raphael Chaim, is very much of that category as well. Many of you are very familiar with him. Certainly any of you have gone through Mount Sinai, know Dr. Raphael very, very well. And he's really a treasure for us to have as a friend of our organization. He goes above and beyond, and like I said before, the same thing. He does not have he might have specific office hours, but he is on call all the time. Patients are calling him random hours. I don't know if he appreciates the 3 o'clock in the morning phone calls, but he definitely gets phone calls at all hours of the day and night. And he's a wonderful individual, really a wonderful person, a talented doctor, and we are very fortunate to have him as a friend of our organization. So Dr. Raphael Chaim is going to come up, we'll speak a little bit, and we'll do more question answer. There's still a lot of questions that people have, and he is very capable of answering them. Without further ado, Dr. Chaim.
Wonderful introduction, thank you. So I'm Raphael, as you guys know me. I see a lot of familiar faces here, which is takes me back to all the good transplant days and all the good moments you as patients had. I don't have any specific topics. I can talk about any topic. I've been doing transplants for about 15 years now. I think one of the first people in the medical field that sort of started working with Renewal, pushing Renewal, and learning about Renewal myself. So it's an honor to speak at any Renewal event. As they know, I'm always available to talk, to answer questions. If it's helpful in any way for patients, I'm pretty happy to do it, just like Renewal. I've been doing transplants, dealing with transplants in different stages as a nurse, as an MP, and a doctoral level, and managed transplants. So I'm one of the managers. I'm one of the person who sometimes can take you from A all the way through the transplant and help you with a lot of different things. So know pretty much a lot about post-transplant, pre-transplant management. I think this is a group of post-transplant patients, so mainly we'll talk about post-transplant. Dr. Kleiner, I think, covered a lot of things. He spoke a lot about different diseases, why you need transplant, what do you do after transplant. What we do is we do transplant, we keep patients usually for about 3 months, then we ask you to go back to your nephrologist. This is somebody like Dr. Kleiner who sends patients to us. We send you back to him in about 3 months. So in general, I know you guys all had a transplant and have a loved one who had a transplant. So what happens when you have a transplant, right? I'm going to try to speak in plain terms so that it all makes sense. And it's really, really important to learn about post-transplant again, especially about 1 year after you do your transplant. A lot of times when I talk to patients, it usually lasts them about a year. And then about a year or 2 years or 3 years from the day of transplant, you see some routine issues that you could totally avoid. And it's good to always remind yourself of what happened to you. You always have to know somebody precious, somebody really, really important, an angel almost. I gave you a kidney. This is not your kidney. It could be your mother, it could be your father, it could be your brother. It doesn't matter who gave you this kidney. For the purpose of managing your kidney post-transplant, this is not your kidney. So your body knows this. Your body's very smart. Your body says, hey, you don't belong to me, you gotta get out. And that's normal. That's how we usually fight infections and flu and colds, right? You get a flu, you get a fever, nobody likes the fever, nobody likes how you feel, nobody likes the runny noses, but that's how your body fights infections. We call it an immune system. We have a great immune system that fights infections. Otherwise, we wouldn't have this. Nowadays, nobody would be alive. You sneeze and people would just die. We have an immune system that fights. So same thing happens. This kidney is a little bit more than just a little disease. It's a huge, it's an organ full of blood in your system that doesn't really belong to you. It doesn't matter. It could be your identical brother or sister who gave it to you, for example. So your body says, hey, though, you don't belong, and your body is very smart. So what we do is we give you medications. How do we call those medications? We call those medications immunosuppressive medications, or we call those medications anti-rejection medications. Basically what they do is they tell your body, hey, don't fight my kidney. And if you don't take your medications, what happens? You'll have a rejection. I'm not trying to scare you, but I can guarantee you, and I see this every day, I can take you to the hospital with me right now, and I can show you patients who are 19, 20, 30 years old, who decided not to take medications and they have a full-blown rejection. Sometimes we can treat it, sometimes we can't treat it. But it's just like having a car accident, right? You can fix the car, when you drive it, it's not the same. So you want to make sure you don't have that rejection. Sometimes you can have rejections because of many different things. The way your body responds to the certain medications, the way your body responds to this new organ that you have, the certain antibodies that you have, the DNA of the organ, a lot of different things that we don't even know a lot about. But that's one thing that you don't need to worry about. As long as you go to the good hospital, good transplant center, you have physicians, just like Dr. Kleiner or others, we'll take care of all the other things. But one thing that's really, really sad to see is patients having a rejection because they just decided not to take medications, right? So that's really, really something you can avoid, something you can control, and something probably halakhically you're not allowed to do. So what do you do? So who usually has a rejection, right? So in the United States, the rejection rate, just in general, is about 10% in the first year. It's much lower in certain hospitals, and it's really low when you get a kidney from a living donor. And we're talking about single digits. So that's good. So who does this rejection usually happen to? It usually happens to older people who don't have family, who don't have support, who don't have people that will help them. That's why every hospital you go to, they always tell you who is your family, who you're living with, who's going to help you, who's going to come with you, who's going to bring you to the appointments. All that is really, really, really important. And sometimes patients try and say, well, let me say I don't have anybody this way, they'll give me transportation. Usually you'll get yourself an exit ticket. It's usually teenagers, so we see a lot of teenagers who have rejections, right? Because they don't listen, they go out, they go to college, they get, they start dating, they do things, and they think that, the transplant or the medications is secondary, or they'll do it later. And so we see that a lot in that community. So we want to make sure this doesn't happen. And then you take the medications. So I usually quickly just break medications in 3 categories, right? You all get about 10 different medications right after transplant. And about a month or 3 months, 6 months, we go down on their medications almost monthly. Medications, so I break them in 3. I say the anti-rejection medications, we also call them immunosuppressive medications. You all know them. So there's different groups, but most of the medications that people use is usually Prograf, Cellcept, right? Sometimes Sirolimus, cyclosporin, or belatacept, and steroids for about 50% of you. So those are anti-rejection medications. Those medications basically tell your body, hey, don't fight my kidney. You have to take them. Okay, the doses may change, but the medications will never stop. You will take them for the rest of your life until your kidneys are working. Hopefully that's for a very long time. We do a lot of research to do transplants without medications. We do a lot of research to give you less medications, to keep the levels low. But I think as a group, we're still 10, 20 years away from doing transplants completely without medications. Okay? So until we come up with something new, you will have to take those medications. The second group of the medications is prophylactic medications, right? Because remember what I told you in the beginning, we keep your immune system down, so it's easy for you to catch infections. That's what Dr. Kleiner was saying, you gotta wash your hands. We keep the infection down, you can catch infections, especially in the first 3 to 6 months, or the first 3 months mainly, because we give you a lot of additional medications in the hospital through IV that are even more immunosuppressive. And so that's why we tell you to take some antibiotics, we tell you to take antivirals, and we'll tell you to take antifungals. And every hospital has their own policies, plus minus. Some hospitals will tell you to take it for a month, some hospitals will tell you to take it for a year, for 6 months. You just follow the directions that your hospital gives you. Okay? Those medications usually eventually stop. And the third group of medications is your home medications. Your blood pressure medications, your diabetic medications, everybody has different needs. I'm not going to discuss them. But just know that the medications, that sometimes a lot of medications that you take before transplant, You're not allowed to take after transplant, and the other way around. That's what Dr. Kleiner was saying. Make sure you always ask. Make sure you always ask your doctors which medications you need. So why do you do this? So we'll go back to the immunosuppressive medications. A lot of people take Prograf here, right? Or something similar to Prograf, cyclosporin or rapamune. So this medication is basically, it's also in medical language called nephrotoxic. It basically affects your kidneys. That's what it means, nephrotoxic, right? It can damage your kidneys, so why am I taking it? There's no other good medications out there that don't damage your kidneys. There are some that are coming out. You take this medication, so we know from research that higher levels of Prograf can damage your kidneys. So that's why we don't want you to take too much. If you don't take enough, if you take small amount, then your body doesn't know you have this medication, and then what will happen? You'll have rejection. So you can't take too little, you can't take too much. You got to take exactly what you need. How do we know what you need? We do your blood work. In the beginning, we do your blood work every day. Then we do it twice a week. Then we do it once a month, once every 2 months. Eventually, you're all sitting here, and a lot of you are here after 1 year of transplant. I always suggest, even if we tell you not to do it for 3 months, I suggest you always do your labs once every month or once every 6 weeks. I wouldn't pass more than that. Even if it's your local doctors. And you're looking for two things. You're looking for your creatinine level, that tells you how your kidney is working, right? You should all know your creatinine levels. And it's different for everybody. 1.1 could be normal for you, and 1.5 could be normal for you. It all depends on a lot of different things. The surgery itself, the type of organ you got, the size, your size, donor size, kidney size. Whatever your number is, for some of you it's 2, for some of you it's 3, that's your normal number. It's always, you can't just trust physicians. Each hospital, there's about 9 transplant hospitals in New York, and we all have about from 1,000 to 2,000 patients on the list, and we manage thousands of patients post-transplant. So I always say, you are your own best physician. You just can't trust people, will forget, people sometimes won't call you. You have to know your values. And the second thing you need to know is the medication level, whatever medication you're taking. So it's really, really important to stay on top of those things. You don't want to miss your medications, as I said. You have to take, you also don't want to just take it. We had a patient who came back 4 months later, and he would say, well, I was always taking Prograf 2 milligrams, and I just didn't check my levels. I was too busy working, and he came with a full-blown rejection, and he was taking his 2 milligrams. What happened is his level just dropped down, and a lot of different things can cause the levels to go down. So that's why it's not good not to go without any notice, without any lab checks for more than a month, or in some cases we say 2 months. Okay. And so he was still taking his Prograf, but the Prograf level was low. It's as if you're not taking it. So we don't want it too high, we don't want it too low. We want it exactly somewhere where you need it to be. And this is a moving target. In the first, if anybody's here about a fresh transplant, we keep the levels up here in the beginning for the first 3 months because the rejection rate is highest in 3 months. Then we keep it a little down. And I'm not specifically mentioning the levels because it's really, really individualized for patients and by each hospital, by each physician. And then we keep the levels all the way here, up to 1 year. Okay, and then depends on if they have any other infections, then we try to keep the levels there. So this is the Prograf, or one of the first medications that you're taking, for example, is the only medication that we usually check levels for. We don't usually check any other levels. All the other medications we usually keep the same. And there's a lot of interactions with these medications, right? So that's why certain antibiotics can actually interact with this medication and can lower the levels by a lot, or can increase the levels by a lot. So usually, Dr. Kleiner said, not to take prescriptions from your dentist. If you have a good dentist, they usually know exactly what to give you. Or it's always, you could always call your transplant center and say, hey, I was prescribed this medication, is it okay for me to take? Most medications are okay to take, but there's a lot of interactions, so you have to just be really, really careful. You also want to watch out what you take for over-the-counter medication. So a lot of you will tell you not to take, for example, Advil or Allergy. So there's a lot of medications that the pharmaceutical companies sell, it's business, they like to sell. They will mix, they'll combine. For example, I always like to give an example of Tylenol PM. So you all take Tylenol PM, you're allowed to take it, it's not a problem, but all it is just a Tylenol mixed with Benadryl. It's just a combination drug. If you look at the instruction, it tells you, hey, it's a great medication, helps you with sleep, helps you with headache. I personally like to take less medications as possible. So if I have a headache, and I'll just take Tylenol, it'll probably go away and I'll fall asleep. I don't need to take the Tylenol PM, that will put me to sleep. Or if I have a little allergy or I need Benadryl portion of it, I'll just take Benadryl. Or if I need both, I'll take both. That's an example of a medication you're allowed to take. But a lot of times pharmaceutical companies will make medications that you're not allowed to take. Tylenol with something else. Tylenol mixed with Benadryl, with Advil, for example. There's a lot of, so you always have to watch out on over-the-counter medications. Okay? Is there anything else you guys want me to cover? I'll be happy to cover. Otherwise, I think I'll take a few questions and then I'll maybe add some more things. Yes?
Hi, when I went to surgery, I got a medication. My kidney failed, the kidney ballastic. Confusion. So now I can go back to regular medication instead of the ballastic.
So who else takes Belastip here? By a raise of hands, if you guys want to. Anybody else who knows about Belastip? Okay. So you're asking if you were taking a medication, probably Program, and then they switch you to Belastip. Again, it's really individualized. I want to make sure I don't give you any wrong information. But there's a lot of research on Belastip. We were actually one of the first centers who started giving Belastip about 10 years ago. Belastip is an infusion that you get once a month instead of the program, instead of the medication that I was telling you that's nephrotoxic. I personally think it's the future of transplant. It's expensive, it's not covered. It wasn't available until about last year for a lot of our patients. So we had, there's a way to get it. And in the beginning, you get it every 2 weeks, and then eventually you get it every month. The benefit of the Belastip is that it doesn't damage your kidneys as much as the other medications do. And it's one of the newer drugs. It's one of the drugs that everyone's studying, but not every hospital, not everyone knows how to get it for you. And there are ways. So to directly answer your question, are you allowed to switch back? Yes, you're allowed to switch back, but I wouldn't. You're on one of the best medications right now. If it's working for you, there's no reason to switch. Any other questions? Yes?
You mentioned about that the doctors say after a year to take a blood test every 3 months. Why do they say that? You and the doctor also mentioned that it's better to do it more often. Is it just because protocol?
The doctors in the hospital will usually come.
What's the questions people can hear?
The question is, I just said to do labs more often than 3 months, but some doctors do tell you to do it every 3 months. So why do we mislead patients? Why do we tell them come every 3 months, right? In general, transplant centers will tell you to come every 3 months, or the transplant centers will tell you come every 6 months, assuming that you'll see your own doctors in between. For a lot of you, if you're like 5 or 6 or 10 years out of transplant, every 3 months it's probably okay to do labs. It's not a contraindication because if you're taking Program, for example, 3 milligrams for the last 5 years, and you most likely eat the same type of food that you eat, whatever you did in 5 years probably will not change drastically. And 3 months is probably okay. I'm just saying in general, if you just had a transplant about a year ago or 2 years ago or up to 3 years, it's just not a good idea, even if some physicians, some of us are really, really confident and tell you, I don't think anything will change in 3 months. I personally, this is just a personal opinion, if I was a patient, I would probably repeat my labs every 6 weeks. That's, again, I'm saying this, that's when I'm completely out of the redwoods, completely like 3 years out and stable and everything is good. I would just still do it every six weeks just to make sure. Because if you do catch, what's the benefit? If let's say we catch something, right? So what's the indicator? When the creatinine goes up, for example, it tells us, hey, something is going on with the kidney. 80% of the time, it's nothing. It's fake, it's not real, it's artificial sometimes, lab mistake, we repeat it, let's say it's still high, sometimes it could be you just had a cold, you were sick, you're dehydrated a little, all that, creatinine reacts to all of this. But those Other 20% will say, you know what, we're not sure why. We keep repeating it, we gave it fluid, it's still a little bit elevated. Let's get a biopsy, let's see. A biopsy is, we go in, we take a little piece of the kidney. It's a 1/1,000,000th of a piece of the kidney. It's pretty simple to do because the kidneys are now here, so it's easier to get to, it's right under the skin. In the literature, they don't report a lot of complications. I've seen it myself. I mean, the worst case scenario we had is mild bleeding, which we had kept patient for more than 24 hours. Usually it's the same day procedure. And that one piece of the kidney tells us everything about your kidney, right? Worst case scenario, if you do have a rejection, we can treat you in 2 days and 1 day and send you home, okay? Out of those 20% that have this, most 80% out of those 20% biopsies are negative. But it's better safe than sorry. But I had patients who were afraid of biopsies and said, I'm not doing it, I'm afraid, I'm fine. Came back 3 months later, had a rejection, and it was really difficult to treat. So first of all, you have to follow what your physicians tell you. They know better, they know you better. You can't just, for example, call another physician, myself, for example, Dr. Klein, and say, hey, I had this, what do you think? And based on my experience, I can tell you something, but it's not always accurate. It's best to follow the physician, especially a transplant doctor who knows you, who's been managing you, who's been managing your program of medications and knows your creatinine and knows how it peaks. And so, and then follow the recommendations. But never be afraid. Never say, you know what, I'm afraid I'm not going to do it, because 3 months later you'll do it anyways, and that'll be too late. Yes?
How much water you should drink?
How much water? So in terms of drinking, again, it's individualized. Let's say everything is good and everything is normal and you had a transplant. So fluids. Fluids is the best thing that your kidneys need, right? So in general, you all need to drink. That includes myself and anyone over here who didn't have transplant. Water is one of the best things. It flushes your system, it's good for your kidneys. There's just endless, there's a lot of benefits. What should you drink? So not sugars and Snapples and sodas. The best thing to drink is water, okay? But keep in mind, everything you eat, soup that you just had, apple that you just ate, also has water. So in general, we say if there's no restrictions, if transplant went well, and everything is working, because it's not always so. Sometimes you have to wait. We usually say you have to drink at least 2 liters a day, at least. But some people lose more, for example. How many cups? You know those Poland Spring water bottles? That's usually 2 cups, right?
This is 1 liter.
Oh, this is a big one, yeah.
No, this is 1 liter. This is 1 liter.
It's a little bigger, yeah.
1 liter is 4 cups.
The small bottles are
So let's say 8 cups, 8 to 10 cups, if this is 1 liter. Yeah.
I have a problem drinking enough water. So I drink a lot of decaf. I also take plain cocoa powder with water and drink that just to add flavor. Is there a problem with that?
So I'm just gonna repeat and generalize your question and say, I can't drink water. Can I drink other things? Right? Yes, you can drink other things. Everything you eat and drink considers to be fluids. Your body needs fluids. I can't picture you not drinking water at all.
No,
right. You don't need to force yourself to drink water. Nobody needs to force themselves. Your body will tell you how much you need. You don't want to be dehydrated. You want to keep that kidney well hydrated. So drinking something decaf is probably fine. Drinking something with sugar is probably okay. It has other, benefits and the risks,
but
right?
plain water with decaf coffee. Just give it flavor.
Yeah, that's probably fine. You also have to realize psychologically it's very, very difficult, and I find it a lot. It's very difficult for you guys to drink, for many patients to drink, because so many years, somebody like Dr. Klein will tell you, you cannot drink, you need to, you have to, when you're on dialysis or you're close to dialysis, they have to restrict you. They restrict you so much. And then when we do the transplant, we go the other way around and say, hey, you need to drink. Psychologically, you're just not ready for this. Because you were so prepared, you were so compliant, you were so trying, and it's so hard to live without water that we find a lot of times I have to convince people, hey, it's okay to drink, you gotta drink. But yeah, you could drink decaf things.
Follow up to that, because since we're all kind of running even over here, what do we do with fasting?
Very good question. So question is about fasting. What do you do? Okay, it's a very good question. So a lot of times I get those questions myself. I like to answer them myself as well. I've seen few professors in the transplant field who give different type of answers. I've seen really good doctors who said, not a problem at all. I've seen very good doctors now who says, no, you shouldn't fast at all. A lot of people answer those questions without really knowing the religious component of it, or why you're specifically asking what it really means to you. So when you ask somebody, the general answer I'm going to give you a full answer, but the general answer that I'm supposed to give you is ask your doctors and ask your rabbis, right, first. So if your doctor tells you you can't eat, then you should not be eating, or the other way around. But that's just general, because I don't want to overrule anyone. I don't want you to go back and say, well, he said it's okay to fast. But when you ask, you really have to ask somebody who will empathize, who will know exactly why you're asking, okay? Because it's really easy for somebody to say, no, you should be eating. What is this? What kind of religion is this? There's no fast food. So when we do transplants, I usually tell patients, look, it depends how far away you're from transplant. First, they'll consult with their rabbis, and of course the rabbis will go with the medical opinion if it makes sense. If it's too close to Yom Kippur, I'll usually say, you know what, the transplant was about a few weeks ago or a month ago. I think it's a little bit dangerous for you to fast on Yom Kippur. You definitely shouldn't be fasting all the other fasts in the first year after transplant. You have to be really, really careful. And some of you do really well, and it's a different story. Yom Kippur fast after 1 year, I personally think that it's okay to fast, okay? And you should probably fast, or at least you should try fasting. But how do you fast? You can't just say, okay, I'm not gonna eat. What you should do, again, an important fast. You shouldn't really keep, certain fasts. The reason you shouldn't is because you need to drink, you need the body to be hydrated, you also need to take your medications. But let's say the most important fast, Yom Kippur, not a reason for you to go and drink and eat and say, hey, I had a kidney. Unless you have other medical problems. How you should fast? You should do it. You should drink a lot of water starting from the day before. A lot. Your body needs to be hydrated. It takes a lot of hours for you to get dehydrated. So that night you'll probably be fine. How do you take your medications? That's another thing. So you take your medications before the fast, the night before, and it's okay to take your medications. So most hospitals will tell you take it 12 hours apart, take it at 9 and 9. Usually it's okay to take your medications about 2 to 3 hours before or after the time that you take those. Okay? So take your medications at the fast. You take your medications at 9, and your fast comes in at 7. You take it at 7. So the problem is the next morning. So that night you don't really need to drink or eat because you just ate and drank. And the next morning you're probably still fine. There's no way if you drank enough you'll be dehydrated. You should still take your medications, and I would just take, for example, my Prograf and Celcept, and steroids if you're taking it with sips of water. Again, which is allowed, and again, that recommendation will come not from me, but from your rabbis. A little bit of sips of water. Then you're probably fine until about 4 o'clock of that afternoon, or 1 o'clock, right? You still don't need to drink. And then you'll see, you will be urinating, you'll be going to the bathroom. And if your urine is light, you're probably okay. If you feel a little dry, if you feel a little dehydrated, if you feel that you need to drink, then I suggest you drink sips of water. You should have that bottle next to you. If you feel that you're getting a little bit dry, then you should drink. But this is where you fast. Most of the time, as soon as the fast comes out, you probably need to have that bottle and need to drink a lot. So it is totally possible. I've done it. I think the patients that know me, that spoke to me before the fast, I usually tell them, if I manage you, I usually tell you to call me so I know your case and make sure there's nothing else going on. If you were sick a week before and you were so dehydrated already, or there's things going around and your creatinine is not perfect, then it's a different story. But in general, after 1 year after transplant, it's possible to fast. It's not a problem, as long as you do it right, in general. Okay, did that answer the question?
The program, you have to take an appointment no matter what, right?
Yes. So, yeah, I'm gonna leave it at that. I don't want people to misunderstand. I mean, so what happens when you skip a program, right? We want the level to be up here. Okay, we have people who actually miss a dose of program and have a problem. And we have people who miss 3 or 4 doses of program and nothing happens. If it was me, I wouldn't want to take that chance. Okay? So we usually tell people, look, if you skip a dose, if you miss a dose, it happens, you forgot. Unless it's too close to the next dose, then take it right away. If it's too close to the next dose, then it's fine. Don't take it to the next dose. Okay? That if it happens.
Too close, I'm sorry. What if it's too close?
Too close, usually I say 4 hours. So if you take your medication at 9 and 9, and it's already 5 or 6 p.m., then you just skip it and take it at 9. If that happens 5 out of 7 days a week, then you have a problem. Okay? Then you need to find a way how to set a reminder for yourself. Okay? Your daughter, your son, your dog, your wife, something. Okay? It's a problem. So when that happens and people miss a dose, again, I don't want you to panic, and if you miss 1 dose, most likely you'll be okay. If it's not intentional, it shouldn't really happen. But in a way, that will answer your question
When you
about.
say program, you mean cell set also, and the rule goes for all of them?
A rule for what?
For missing, because you mentioned program specific.
All medications.
All cells.
Unless it's too close to the next dose. And we usually tell you, call us. If you miss a dose, call us, we'll tell you what to do. Okay, and sometimes I'll have you take a little bit more that night, instead of, let's say, taking 3 and 3, sometimes I'll tell you, take, again, I don't want you to come out of here and self-manage things and say, you know what, I think based on what he said, this is what I will do. I'll take a little more, or I'll skip a dose and nothing will happen. Like I said, we have people who skipped a lot of doses and nothing happened. And we had people who skipped 1 dose and something happened. And we also had people who skipped 2 doses, nothing happened, and they said, no, they can skip again, they can have this again, and then something can happen. And sometimes we don't know if something happened. Sometimes maybe your body started doing something, and by the time we checked you, and by the time you took this medication again, your body was able to resolve it. There's a lot of things we don't know either. As major hospitals, as nurses and physicians, immunology is an interesting field. It's not an easy field. Transplant is not an easy thing. You didn't have just a regular surgery where you had a knee replacement, right? And you had exercises, and you were able, they taught you how to walk again, and then you started running, and then you run around and you do things. It's not like this. Transplant is not like this. Your surgery is only 10% of it. You either live or you die, right? Most people live, 99.9%. We have really good, excellent surgeons. The other 90% is how you manage yourself. Your health, which Dr. Klein, I'm trying not to repeat a lot of things that Dr. Klein said, but your health is extremely important. What you eat, how you eat, what you drink, sleep, gaining weight, and all of those things are extremely, extremely important. If you think you had a kidney transplant and now you can do anything you want, then you're making a mistake. You'll get back. You'll go back to the point where you were 5 years ago. The kidneys can last a very long time. We have kidneys that lasted 40 years, for example. We have kidneys that lasted 1 year, 5 years, 10 years on average from deceased donors, 20 years on average from living donors. So you got to take as much as you can out of these kidneys. And what we did 20 years ago, we completely changed what we did 20 years ago. And I wasn't doing transplants 20 years ago, but things changed, medications changed, side effects, the levels, and a lot of things changed. So who knows what we're going to be doing 20 years from now? There's a lot of research we're doing. So you want to keep this kidney, you want to keep it for a long time, you want it to last as long as you can, because you never know, 20 years from now, there'll be more new opportunities. Yes?
I take all my medication in the morning at the same time. Is there a side effect with each other? Sometimes I was thinking maybe I should take it every 5 minutes.
General medications, I don't know your list. Most medications are okay to take at the same time. Let's say 9 and 9, not a problem at all. We looked at all of them. And again, I'm not talking about specifics. I don't know the list that you're taking. But if you follow the medication, remember guys, the goal of transplant was for you guys to live a normal life. To go back to work, to go back to school, to see your grandkids, kids, to go to the weddings, to go travel and to do things eventually, right? If you follow each medication recommendation, it'll tell you take this medication at 9, this one at 10, this one 2 hours after that one, this one 3 hours after that one. The goal is not for you to take medications on the hour every hour. What's the purpose of transplant? So we looked at most common medications. It's okay to take all of them at the same time, and this is how you like them. If you like to space them out, then you could space them out. What I usually say is the medications that you take twice a day, you should try to take them on time. If it's a medication that you take once a day, you could maybe, if you have, some people have stomach issues when they take medications, maybe you could delay it a little. What happens when you delay a little, when I tell people you're allowed to be a little bit flexible, they get too flexible. They take it at 9, and the next day they take it at 12, then they take it, and then they move their times, and then it becomes 2 in the morning, they'll never remember, then they forget. So you don't want to get yourself to that point. But most of your medications that were given to you, usually you can take it all at the same time, okay? It's better to also take them with food, because food sort of protects and coats your stomach, and it's just better to take a little bit of milk, a little bit of food, not to have any stomach upset.
Yes. Do you have any advice for prevention of infections besides the hand washing?
Stay away from sick people. Washing hands protect you from 90% of the infections, 90%, if not more. Okay, so after transplant, again, the goal of transplant was for you guys to live a normal life. You're not going to live in a bubble. We get sick, I get sick, you will get sick, everyone will get sick, okay? That's just normal. You gotta protect yourself by staying away from sick people. So if you have sick people, let's say you go to shul, and there's a lot of people in the winter, and there's always somebody who's sick. People that are sick shouldn't be coming to shul. Some people come anyways. So you gotta wash your hands, and you don't need to be crazy about it. You don't need to wash your hands every minute, but it's just normal. It's a hygienic rule, but our religion also teaches us this, right? Washing hands. So if you greet people, you should be washing hands. People, we don't, some centers make you wear masks. We don't make you wear masks, for example. So if you see sick people, infection usually travels 3 to 6 feet steps. I'd say so. Stay away from those people and then wash your hands. You should be okay. But again, you don't need to feel like you need to live in a bubble, walk with gloves and then masks and the goal of transplant again was for you to improve your quality of life, not just get a kidney and stay at home. That's not why those donors gave you those kidneys. You all had really great stories, right? You all wanted to do things, and those donors really felt for you. They all wanted you to live. Okay. Any more questions?
When can you
Fly. So fly, we usually say depends. Depends again. Ask your doctors again, but usually we say wait 6 months before you fly. Depends how far you fly. Flying for a long time can cause, it also depends on why you had a transplant, what your medical history. Flying a lot can cause blood clots. At the same time, we transplant people from Saudi Arabia, from Israel a lot, and we let them go back a month from transplant. Because they have to, that's where they live, and I can stay here for 6 months, right? When I say when you fly, make sure you walk every hour, every 2 hours. Don't just stay in one place. Get your circulation going. When you fly, there's always somebody sick in an airplane. There's no air, and so sometimes you can also get sick. So we usually say right after transplant, wait for 6 months, and then again, you're there to live a normal life. You're allowed to fly. Just be a little bit cautious. Any other questions? Okay, thank you.